you. Thanks, Shane. And thanks also again to all the organizers of the Queer in AI workshop to present. I've been incredibly thrilled to be here and listen to such incredible presentations today and learn from everybody here. So I'm very grateful to be invited to connect with all of you and share some reflections with you this afternoon. And as Shane said in both of my introductions. I'm a sociolinguist, which means that I'm very interested in the ways that language and society interact and influence one another. And most fundamentally, I'm really interested in the ways that language carries certain social meanings and the way that we use language to do certain things interactionally. And it's a really exciting time to be a linguist because whether the public knows it or not, linguistics is kind of having a bit of a moment right now. And especially following the release of ChatGPT-4 in March of this year, LLMs are becoming increasingly ubiquitous and their use cases are expanding seemingly by the day. And among the top sectors that are projected in making substantial use of this technology is the healthcare sector. And in reality, various AI tools have already been in use in healthcare settings for some time, but we're looking at a potentially greater future of even greater AI integration, one that uses LLMs to support various aspects of clinical encounters. So researchers and industry professionals in the rapidly evolving commercial landscapes of AI and machine learning have argued that AI-supported patient care technology has the potential to transform the future of healthcare. And among the innovations that experts have proposed is the potential for example, expediting medical research by testing compounds for drugs or vaccines and so on in computer simulations, which is faster and also comes at a much lower cost than traditional laboratory testing. Also reducing time spent on administrative tasks like note-taking, transcribing notes, reviewing and summarizing medical records, identifying abnormalities in medical imaging, and creating personalized treatment plans for patients as well. And somewhat relatedly, we may also see more widespread adoption of AI-powered chatbots, right, in the form of health assistants that can take basic patient information, schedule appointments, and maybe even provide diagnoses themselves. So each of these advancements, though they're still in various stages of development, have been celebrated in the media for their potential to alleviate strain on healthcare professionals by reducing burnout, helping fill gaps that result from shortages of medical workers, and also reduce human errors that arise due to oversight and exhaustion. But even more than that, patient-facing technologies in particular have been celebrated for their potential in improving not just the quality of care, but also improving communication between patients and their healthcare providers. But the question that I want to ask is, what does it mean to improve communication through further AI technologization? And as a researcher of health inequities that arise in doctor-patient communication, I found myself reflecting on what, if anything, that research can contribute to the future of healthcare access for transgender and gender diverse people, especially as the future of healthcare is itself changing. So in my talk today, I want to linger a little bit on the tension between these pre-existing inequities in healthcare settings and the optimism about AI technology's potential to resolve them. In particular, I want to consider quite seriously this question of what it means to improve communication in terms of how AI-based technologization of healthcare settings might impact gender diverse communities and what some of the top considerations might be for ensuring health equity for transgender and non-binary patients. In other words, how do we continue to move towards reducing and ultimately eliminating health disparities for gender diverse patients as we potentially enter another AI summer of development? And in doing that, I'd also like to consider how a socio-linguistic perspective on doctor-patient communication might contribute to, say, bending the arc of technology towards good. So throughout this talk, I'll be drawing on frameworks of linguistics for social justice and also AI for not bad, which is just a slight reframe on the more common, increasingly buzzwordy AI for good. And my hope is that in bringing these, the values of these two professional practices together, I can actually make a compelling case for sociolinguists, social scientists, and community members of diverse specialist areas of expertise as essential collaborators in the development of LLM-powered tools. So I'll begin by providing some background on gender affirming care here in Ontario and introducing some of my own research on non-binary patient experiences here in the Greater Toronto Area, including some of the key insights and strategies that my research collaborators shared on how to maneuver around the canonical medical knowledge and diagnostic classifications that excluded them. And then I'm going to introduce three major areas of current development in generative AI technology and identify some of the considerations for the development of these tools in healthcare settings from the perspective of health equity for trans and gender diverse populations. And then finally, I want to bring these two previous sections into closer conversation with each other in the form of some final thoughts and highlight some core areas of intervention and collaboration in ensuring that medical LLMs not only account for gender diversity, but are as affirming as possible. So as I mentioned previously, I myself am a researcher of healthcare settings and specifically of healthcare interactions. And for my dissertation research, I conducted a sociolinguistic study of non-binary patients' experiences accessing gender-affirming care here in the Greater Toronto Area. And just a quick note that gender-affirming care, as I'm describing it here, isn't just referring to a quality of care, but a particular type. So this is any care that individuals access in order to bring them greater ease in their bodies and identities. So this could include hormone replacement therapy or surgical interventions and so on. And this research is based on ethnographic interviews with 17 non-binary patients who were then currently in the process of seeking this care, and also a computer-assisted discourse analysis of some extensive online ethnography in trans and non-binary internet forums. I'm only going to chat about the in-person interview aspect today, but I'm glad to discuss more about the virtual ethnography as well, if there's interest in that. So my participant collaborators for this project were of diverse ages and socioeconomic statuses and racial and gendered identities. But one thing that they all had in common, one thing that they all shared, was a high level of attunement to how they talked to their healthcare providers about their identities in pursuit of medical support. So my qualitative analysis of these interviews identified the specific linguistic strategies that patients employed in their doctor-patient communication to simplify and sometimes even obscure their non-binary identities as a result of narrow diagnostic requirements and lack of practitioner knowledge of gender diversity. So the formal requirements of a diagnosis in order to access gender-affirming medical support is something that's left to provincial regulation here in Canada. So each province requires different numbers of practitioners to validate a diagnosis depending on the specific support that a patient is seeking. So in Ontario, for example, hormone replacement therapy and upper surgeries require only the sign-off of a general practitioner, so one family doctor. But lower surgeries also require additional secondary, sometimes third referrals from a psychiatrist or other specialist as well. But so with all of that said, how did doctors even do this kind of diagnosis? Well, previous research has shown that doctors' assessments of transgender patients, transgender and non-binary patients, remain largely based on the criteria for gender dysphoria presented in the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5 for short. And in the DSM, the American Psychiatric Association defines gender dysphoria as clinically significant distress or impairment related to a strong desire to be of another gender. And indicators or symptoms, if you will, of dysphoria range from wanting to play with the toys of another gender to a child to a strong desire for different sex characteristics. I do want to note here that the term dysphoria itself has actually already been in use in transgender communities for decades to refer to the discomfort that many individuals feel in relation to their sex assigned at birth. But in the DSM, this discomfort is framed in terms of a symptomatically diagnosable pathology, one that is a deviation from normative cisgender development. And it also recommends dysphoria as a necessary condition for receiving gender-affirming medical interventions. There are more affirming guidelines out there than the DSM that take a much more expansive view of gender identity and that suggest a much more collaborative and personalized approach to gender affirming care. So, for example, there's the World Professional Association for Transgender Health's Standards of Care. The 8th edition just came out this past year. And there's also the World Health Organization's International Classification of Diseases. The 11th edition of that came out in 2019. But regardless, the DSM-5 still remains the primary, if not the sole text that's taught and used in gender-affirming diagnostics and in psychiatric care more generally, certainly here in Canada, but in various places throughout the world as well. And there are a multitude of reasons as to why doctors rely so heavily on this particular text, on the criteria of the DSM-5. But knowledge of transgender communities plays a very, very strong role. So for many healthcare providers, this is the only account of transgender experiences that they're exposed to or that they access regularly as part of their clinical training. So doctors' knowledge of transgender care remains very, very low, and the majority of care providers receive little or no training in queer and trans healthcare. So for example, a survey of 150 medical schools in the United States and Canada reported a median of only 5 hours of instruction dedicated to queer and trans content in the entire medical curriculum, which in total averages nearly 1,500 hours of contact time. So many healthcare providers are unfortunately unfamiliar with providing gender affirming care entirely, but let alone in consultation with non-binary patients whose experience of gender does not necessarily align with canonical medical criteria. And as a result, there remains an impression amongst gender diverse communities that there is only one ratified narrative of transgender experience that doctors will recognize and understand, which many of my participant collaborators refer to as the right story. And this has resulted in a further impression that accessing gender affirming care is a kind of test and one where patients must do their gender in a particular way in order to access care. So that is in a linear binary way characterized typically by the acute suffering described in medical texts. This is not how many transgender and non-binary people understand their experiences, though, right? Not all transgender and non-binary people necessarily view themselves as dysphoric, as moving away from suffering. Instead, many view themselves as moving towards euphoria instead, and reject dysphoria as a defining criterion of trans or non-binary identity. But since identification outside of an assumed binary sex and gender classification has historically meant losing access to gender affirming support, non-binary patients often find themselves using different language to describe their experience in this encounter simply to gain access to the care that they need. So to mitigate the risk of this refusal in these clinical encounters, my participant collaborators reported a range of interactional strategies to invoke diagnostic criteria and bridge the knowledge gaps between themselves and their doctors. So this includes, for example, the flexible use of identity terms, so particularly ones that patients perceived to be more recognizable to their doctors. So for example, rather than using non-binary, simply using trans or transgender, or terms that are maybe more common in the medical literature like FTM and MTF, or simply transgender man or transgender woman. So as one of my collaborators, Roma, recalled, I'll definitely use trans when I'm talking to the healthcare professionals. I'm a lot less likely to leave that word out because then it leaves room for maybe you're not. So even though trans isn't a term that Roma uses to describe themselves outside of the doctor's office, their concern about potential consequences of not using the specific label trans outweighed their desire to use different, perhaps more accurate language like non-binary. And because of presumed limited exposure to transgender experiences, this is one strategy to communicate to their doctor that their experience is genuine and making it recognizable by anchoring it in more familiar language. As another one of my collaborators, Noah, described, you try to align it to something they might know or recognize as legit. But in seeking recognition by their doctors, patients also sought to invoke diagnostic criteria for gender dysphoria, intensifying their descriptions of dysphoric feeling and also historicizing it as a long-term experience, such as anchoring it in childhood or adolescence to amplify the urgency of their care and avoid potential administrative delays that may result from being deemed a potentially unserious case. And because diagnostic criteria specify that indicators of dysphoria often emerge in childhood and are typically experienced over a very long period of time, it's common for patients to be asked by their doctors how long they've been experiencing discomfort in their gender identity. So this is another excerpt from one of my collaborators, Theo. So Theo here is recounting an interaction with their doctor where they were asked to describe their gender in their youth as part of a consultation for a gender-affirming procedure. And here they're recounting, describing their experience in grade 10 when they were a high school student, a time when their gender presentation differed quite differently from the present. So since they presented very femme at the time, Theo felt compelled to justify this difference to their doctor from their current gender expression so that she didn't draw perhaps an essential link between those positions. So she didn't think that was who I was. So here, Theo not only historicizes their dysphoria by, in their words, harping on how their previous feminine expression was a lie, but they intensify its effects and describe themselves as having been so sad and restricted by the peer relationships at their very conservative high school. So Theo describes recasting this previous gender expression as having been rooted in dysphoria, discomfort, and dishonesty, even though that was not the case for them at the time, right? So they didn't know yet that they were non-binary. And in contrast to mainstream understandings of gender identity, this realization arrives for all of us at very different times. And so for Theo, the fact that they expressed their gender differently in their childhood was a non-issue, right? So they're matter of fact in stating to me in our interview that this was just something that happened, and now that's not what happens anymore, and these things change, and that's fine. But Theo understood their doctor's questioning as indicating her desire for a neat and coherent narrative, one in which they somehow always knew that they were non-binary. And rather than risk being denied access to their surgery on the grounds of insufficient medical dysphoria, they obliged. But in pursuing this kind of legibility, the quality of patients' care is also deeply compromised. So for example, my collaborators also reported avoiding asking questions about their gender affirming treatments out of a concern that such questions might inadvertently indicate that they were uncertain about their need for that care and therefore not trans enough for a diagnosis. So a striking example of this comes from Keaton, who in this excerpt has just finished describing a meeting in which they were also seeking access to a gender-affirming surgery. And though they generally evaluated this interaction with their doctor quite positively, they also noted their own hesitancy to ask their doctor pertinent medical questions regarding the procedure itself. So Keaton recalls that at first the doctor questioned them, probing about their desire for surgery, their past experiences related to gender, the extent to which they felt that their surgery would alleviate these dysphoric symptoms. And afterwards, she asked them if they had any questions, and they did. But they described themselves as being so thankful for the doctor's willingness to support their application for surgery. They didn't want to say anything in case it undid that interaction, right? In case they asked the wrong question that would erase that whole experience. So Keaton had two legitimate medical concerns, ones they'd read about online from other patients who had undergone this surgery before, but in shying away from their own questions, they appealed to the medical institution's connection between the need for care and an experience of dysphoria. So in their words, they say anyone with enough dysphoria wouldn't care if their bladder prolapses. So the primacy of dysphoria as a diagnostic criterion may lead patients to believe that it has to trump all other things, right? That it supersedes outcomes or even risks. And so for Keaton, posing questions risked communicating to the doctor that they're not sufficiently dysphoric and consequently not sufficiently confident in their decision to pursue care. But for any procedure, patients should be able to ask whatever questions they need in order to feel confident and secure. And since the diagnostic model makes it challenging for gender diverse patients to trust their healthcare providers, it's challenging to engage in the interactional collaboration necessary to arrive at that confidence and security. So in light of the medical authority that's suffused in this interactional setting and the constraints that it places on individuals' behavior, linguistic practices are key tools for patients to navigate expectations for gendered presentation in the consultation room with their doctors. So in other words, whether they get access that they need often depends not just on what they say, but how they say it and what they strategically omit. And given the extremely elevated rates of depression, anxiety, and suicidal ideation among gender diverse people relative to the general population, impacts of societal sexism, access to this care can be essential to individuals' well-being. And it's for this reason that gender affirming care is often described as life-saving. And as a life-saving form of medical care, interactional moves towards securing access can feel highly consequential, and the balance of power can feel particularly vulnerable. And insofar as gender affirming care requires an interactionally mediated diagnosis, transgender bodies and their treatment are at least in part a language oriented concern. Gender identity is not inherently a readily observable characteristic. It's not discrete, it's not static. And in this context, under this model of transgender care, it can only be described by patients to their doctors who evaluate those descriptions for accuracy and consistency with medical texts. So there are effectively two prongs to the inequity of doctor-patient communication in this context. So first, the insufficient and problematic nature of a diagnosis-based model to begin with, one in which gender diverse patients are made patients simply by virtue of their status as non-cisgender people. And this largely arises due to the limitations of canonical medical texts and a dearth of knowledge among medical practitioners. And second, the interactional work that non-binary patients must do to bridge the knowledge gap with their doctors. This can be simultaneously empowering in gaining access to much needed care, but it can also be constraining in limiting not only individuals' self-expression, but also their ability to make informed decisions about their care as well. So for one, this brings into stark relief how the development of medical LLMs would likely struggle to take into account the problematic nature of diagnosis for certain conditions, particularly those pertaining to identity that again are not measurable, discrete, or static, but it's also an entry point into some other essential interactional considerations for ensuring that AI-supported patient care technologies account for and are affirming of gender diversity. Because if our current human practitioners don't recognize us, how do we ensure that an algorithm will? And before I dig into that particular point in more detail, I want to get a little bit more specific about what kinds of technologies I'm talking about here. So healthcare is currently the largest market for investment in the emerging AI and machine learning business sector. And this is an extremely broad domain. But the current emphasis on AI in healthcare dovetails with a particular narrow and empirically inadequate framing of health, and that is the diagnostic medical model that I've been talking about. So the majority of development efforts have focused on clinical care and disease diagnosis. But at the same time, this takes place against a larger backdrop of persistent underinvestment in upstream social determinants of health and the public health sector more generally. And despite not having created these inequalities originally, big data analytics and AI systems still are in many ways primed to exacerbate and conceal them. And in pursuing generative LLM solutions to diagnostic processes specifically, one of the main ways that this can manifest is by effectively tailoring treatment and diagnostics to ever narrower groups who are recognizable and treatable with this kind of technology. So there's a wide range of specific use cases being tested for generative AI technologies in healthcare settings, but I'm going to focus on three pillars of development receiving some of the biggest cash flows from tech giants like Google and Microsoft, and which intersect also most crucially with doctor-patient communication. And these are medical LLM-trained chatbots, AI simulated clinician training, and ambient clinical intelligence. So medical chatbots are pretty much exactly what they sound like. So these are conversational bots trained on medical LLMs designed to provide high quality, accurate, and authoritative answers to medical questions. And in the ideal case, these bots would respond accurately to patient and practitioner queries and maybe even provide diagnoses and treatment recommendations, potentially expanding telemedicine offerings significantly. Google's MedPalm 2 chatbot is one example of a medical LLM in development potentially for this purpose. So this model, which is trained on foundational medical and scientific texts, recently achieved an 85% score on the USA medical licensing exams, which is on par with human experts. And it's also the first medical LLM to achieve a score this high, let alone a passing score at all, actually. And as with all LLMs, of substantial concern, of course, is the potential for chatbots to replicate inequities, right? So there's understandably the risk of perpetuating the racism, sexism, transphobia, and other forms of prejudice that persist in medicine and which persist within foundational medical and scientific texts as well. So an especially pertinent question at the outset is whether transgender and non-binary patients would even be able to use tools like this without misgendering themselves. So for example, existing medical chatbots like Ada require users to make a binary choice between male and female at the very beginning of the encounter. So in this case, when you tap the text, why only these two, the bot acknowledges that there are more gender identities than just male and female, but the algorithm can currently only differentiate between these two. So this is a very illustrative response in many respects. First, it is indicative of the fact that the model collapses sex and gender by design. So note that male and female are sex categories, they're not genders. And in addition to precluding access by intersex users, this also ignores diagnoses and treatments where the interaction between sex and gender would be clinically significant. So this is true, for example, for hormone replacement therapies, sexual health and HIV prevention, mental health, and also certain cancer risks as well, just to name a few. But by combining sex and gender into one variable, these tools exclude gender diverse people, again, by design. And to the extent that a bot can know anything, right? Because it's not sentient, it can't know anything. But to the extent that it knows anything, can extrapolate any patterns from its input data, it does not know that gender diverse people exist. And this would result in undeniably poorer care for gender diverse people in comparison to cisgender counterparts. But even if a model could differentiate between sex and gender, there are still a number of outstanding questions to consider there. So for example, what would the training data need to be in order to do that, right? How would its quality need to be assured? And who would need to be involved to supervise the training and validate the output? And how might such a model respond to a patient seeking gender affirming care if it could, hypothetically? How might it respond also to gender diverse patients who are not seeking this kind of care, despite the weighted probabilities in model data indicating a high likelihood that they would be? Right. So depending on the medical literature and patient histories included in the data set, conversational medical LLMs might also risk replicating trans broken arm syndrome, which is a form of medical misattribution in which a provider incorrectly assumes that a medical condition results from a patient's gender identity or their transition status. So if patients are able to self-identify as transgender or non-binary and data points on gender diverse individuals correlate highly with transitional therapies, this might also be over-recommended as a treatment when it's either not desired or is just not pertinent to an individual's present healthcare need. So this might point to the need for some potentially task-specific training in gender diversity alongside the inclusion of specialist-led resources on primary queer and trans healthcare in input data. Because if such a bot were to be able to serve gender diverse patients in any capacity, as maybe any healthcare bot for the general public should, a range of domain experts would be necessary to assess a model's readiness for deployment. But many developers already do recognize that contemporary LLMs are not quite yet safe enough for the complex practice of clinical diagnosis and have chosen instead to focus on supporting the many other applications of LLMs in healthcare. So on the side of practitioner benefit, AI simulated clinician training uses similar LLM models to generate realistic patient cases with their own unique medical history, vital signs, physical symptoms, and emotional states. And these models are intended to power tools for medical practitioners to develop and refine their clinical reasoning and decision-making skills in virtual settings. So San Francisco-based startup Hippocratic AI is developing one tool like this that would allow medical students to chat with AI-generated patients and take their history, conduct exams, order tests, and formulate diagnoses. And they can also receive feedback on their performance across different domains, from communication and bedside manner to pharmacology even. So an upside to this kind of virtual clinical training is that it could hypothetically present a great opportunity to give practitioners greater experience with gender diverse patients, albeit fictional ones, and test their skills, right? So for example, it might make a good complement to a training module for clinicians in various forms of specialist care without having to put real humans in positions of medical harm. But ensuring the quality and expansiveness of patient vignettes would be essential, since the same root issue is at risk here as for other medical LLMs and LLMs more generally, right? Namely, what are the training data and how has its quality been assessed? Particularly because this involves the generation of fictional patients, there's also a risk of replicating static categorical types of gender diverse people based on those most widely attested in the model data, which could potentially exacerbate medical discrimination through one-dimensional representations. So the last and potentially most promising of the non-diagnostic offerings of AI in healthcare is ambient clinical intelligence, or ACI for short. So ACI uses advanced voice-enabled AI to automatically document patient encounters during natural, free-flowing conversations between physicians and their patients, giving them more time to engage with patients themselves. So Microsoft, for example, recently acquired a Montreal-based company, Nuance Communications, to develop their own platform for this, which would record details of the doctor-patient encounter into a patient's electronic health record and promises to contextualize every word of the encounter as well. So this kind of clinical technology does have an advantage from a practitioner standpoint of reducing administrative strain, right? Maybe facilitating some more attuned encounters and maybe even increasing intake capacity as well, enabling folks to see more patients than they would otherwise. Capitalism loves productivity. But that said, it doesn't automatically entail improved communication from a patient care perspective, right? So that onus is still on the doctors themselves, right? So in regards to gender affirming care or any form of primary care for gender diverse populations, it still can't address that parallel concern of the upstream knowledge gap discussed previously. And while there are still important equity considerations in terms of system design, like maybe how patient demographics would be extracted from natural speech data, there are some practical implications of this kind of tool. That's fair. So clinicians spending less time documenting and more time in conversation with their patients is maybe kind of the best case scenario here, right? So if AI is to improve communication in any way, it's probably by facilitating more human to human patient-facing contact. So now some final thoughts. So even though it maybe goes without saying, it's still worth repeating, I think. AI technology will not be any more objective or affirming of gender diversity than human practitioners already are, at least not automatically, and particularly if trained on data that are exclusionary to begin with. So training models on canonical medical texts will be problematic for populations whose medicalization has come with a history of violence baked right into it. And diagnosis-based models of gender-affirming care are inequitable for gender-diverse people at the outset. And AI models that rely on diagnostic criteria will only replicate existing barriers in access to care. But I think this also highlights what amounts to bigger picture limitations in offloading the interactional activity of diagnosis to an algorithm. But also better communication is not the result of more or even better data. So queer and gender diverse people have already got very good reason to be wary of algorithms, given the many ways that they can be used and are used already to automate oppression. And we've seen some very significant examples of this throughout our session today as well already. So there's also a need then to contest and reframe conventional positivist approaches to knowledge and data that deprioritize interpretive, contextually attuned research. And this is all the more important when working within social institutions like healthcare, where the politics of diagnoses and illnesses are not to be taken for granted, right? Such as in the case of gender affirming care. And we also have to actively resist attempts at an innovate first and add equity later approach. So the conflation of sex and gender and the encoding of binary sex and gender categories aren't just starting points to be resolved later, right? They're barriers in the bedrock of our models. So any model that assists and benefits queer and gender diverse people will take into account their identities and actively strive to improve social equity. Otherwise, as our conference organizers so accurately observe, any model created without queer people in mind and is band-aided after the fact to protect them from harm will still inevitably harm them. So the choices made by developers and healthcare professionals, practitioners and policymakers and other stakeholders in the coming years are going to be critical in shaping the evolution of these kinds of technologies. And as the trajectory of development for AI applications in healthcare continues, it requires specific skills and expertise. But this expertise extends beyond clinics and beyond healthcare practitioners themselves. So this begs the question, who is at the table and who is involved in the decision making? So there's a strong need for diverse and interdisciplinary collaborative teams dedicated to this work at all stages of the development process. And this is true not only for gender diversity, which doesn't stand alone, but also requires community engagement across intersections as well, right? So including racialized communities, disabled and neurodivergent communities, and other groups who have been invisibilized by healthcare institutions. And while medical experts are, of course, key, social scientists and community members are also ideal collaborators with the firsthand knowledge and essential skills needed to anticipate, monitor, and manage the complex effects of technology within their communities. And here's where I want to plug sociolinguists as especially advantageous collaborators and call on my fellow sociolinguists to consider possible AI applications of their research. So sociolinguists study how language is used in different social contexts, and this includes doctor-patient communication. So they can contribute significant expertise in understanding how language is used in healthcare settings or in any given use case setting, including the impact of cultural, social, and linguistic factors on effective communication between doctors and patients, improving the quality of communication and ensuring that systems are attuned to cultural and linguistic diversities. Sociolinguists also focus on understanding and promoting patient-centered care, which emphasizes the importance of communication, collaboration, and patient empowerment, and shared decision-making. So they can also then contribute to designing AI systems that align with these patient-centered care principles, again, considering the cultural, social, and linguistic dimensions of healthcare interactions. So human trainers of healthcare LLMs, of medical LLMs, should ideally be attuned to how doctor-patient communication works and how medical authority impacts the information that doctors receive from their patients. So ethnography, participatory research, and other qualitative social science methods are crucial to informing the development of affirming models for relevance, representativeness, and also technical quality. Because without contextualized evaluations grounded in these kinds of interdisciplinary collaborations, computational and socio-technical methods for achieving fairness in LLMs will encode the concept only very narrowly. But development teams that are equipped to notice when value tensions arise between use cases and the potential for harm and are able to name and frame that tension in a way that enables intervention are best prepared to find the most affirming outcomes. So regardless of whether they power diagnostic or non-diagnostic tools, medical LLMs still require a diversity of tactics to ensure their safety. And Today, I've really only scratched the surface a little bit on just one dimension where this matters, but it's a much bigger and much more pressing issue, especially as we see more and more funds directed to the development of this kind of technology. So consideration of gender diversity in AI-supported patient care is a reminder of the health inequities that exist for populations prior to increased technologization and that are not resolvable by technocratic solutions alone. And concerns of health equity and social justice in the generative conversational AI landscape are also matters of language and linguistic representation and must consider the social life of language itself. And I think this is where conferences like this one are all the more crucial as a community that bridges scholars and innovators in both academia and industry and is devoted to raising awareness of queer and trans issues in AI and advocating for their solutions. I think maybe no one is better positioned than we are to facilitate these connections. Because as people who develop, who create and apply AI and machine learning technologies, we can shape some of society's most powerful elements, but we can also witness some of its most destructive effects. But with intention, we can ensure that AI-supported patient care does not replicate existing health inequities for gender diverse people or innovate new ones altogether. So thank you very much. There's also a link to the slides and the bibliography for the talk at the QR code there as well.
Yeah, thank you, Lex. This afternoon's sessions have been great to really show us the possible risks of harm to the queer communities from this transformational technology that is growing and growing in impact. So I guess, are there any questions for Lex?
Hi, it was a great talk. Thank you. Um, I want to ask your personal opinion on would you like to see diagnostic tools making diagnosis about trans people? Because as you mentioned, they are not in the state to do these kind of things. But also, if you like don't try to do that, then you could make transness disappear even more, because people, I mean, the medical establishment could say like trans people are disappearing because they're not being diagnosed, and it could be because they are not being diagnosed but by these AI tools, right? Because they haven't even been included in those kind of diagnoses because of these risks. So I wonder, like, what's your personal opinion on this? I think, yeah, it's a very difficult topic.
Yes, yeah, it's almost a Black Mirror episode in many ways. The prospect of diagnosis via a chatbot. But I think that my personal view, or at least as someone who has collaborated with patients who are seeking greater equity in gender affirming care contexts, is that probably not. Probably this is not an ideal platform for patients to be accessing that kind of care, but that doesn't necessarily pertain just to gender diverse people, but is actually highlights some bigger complications about, again, offloading the process of diagnosis to a bot in general. So I think that in this case, I would probably say, in terms of clinical best practices, it seems ill-advised, but I think that applies also to various aspects of diagnostics that don't even pertain to gender diverse populations, given the complexity of diagnosis as an interactional process, as something that takes place between a doctor and a patient. Certainly at this stage, large language models are not currently safe enough. We, I think, have not gotten to a point yet where we're able to mitigate bias in a way that would facilitate the safe use of those kinds of systems. So my personal perspective is probably not. And I think that there are maybe other ways that AI and LLM technology could be applied that could have more affirming outcomes, but not in the realm of diagnostics specifically. Yeah. But thank you for your question, Juan.
Yeah, thank you for a really excellent talk, Eddie, he and Brennan. Yeah, do you see your work being used to create guidelines for medical professionals to have respectful conversations? Because like I've been seen by a GP, a quote unquote gender specialist, 2 psychiatrists, and a surgeon now. And my experience of their language use has been incredibly varied. And yeah, like guidelines would, I think, maybe be useful so they don't ask questions like, but what is your partner's cisgender?
Yes. Amazing. Yeah. Yeah. Thanks, Eddie. I too have had my my dance card punched by many practitioners, had a range of interactional experiences there. I think, yes. So I've collaborated previously with the Royal Canadian College of Physicians and Surgeons on putting together some training materials for healthcare practitioners. But also going forward, I also have a plan to create some community materials as well. So fingers crossed, maybe sometime within the next year or two, I intend to have a graphic novel coming out, documenting some of the patient histories that I chatted about in the dissertation. But I agree, because I think that is a very, very strong parallel concern here, is actually just the knowledge gap amongst practitioners themselves. And so I think that in drawing attention to that, that's not to say that just to I suppose, heap scorn on this kind of technology, but rather just to say these are still human considerations that we have not yet resolved. And if we do not direct the requisite attention to them, then we're only going to exacerbate the state of affairs. So the short answer is yes, absolutely. Yeah. Thank you.
Great, thank you.
Hey, Lex, great talk.
Thank you.
My question is actually very much related to your question, Eddie, in that, so in this talk, he sort of talked about how these models are being framed as a way to improve communication when really what they're doing is just offloading the work of communication onto a bot. But I wonder if you have thoughts on how sociolinguists or sort of computational sociolinguists could help in improving doctor-patient communication in general and sort of starting there rather than kind of like waiting for the bots to catch up. Right.
Yeah, that's a really, really, really good question. Yeah, thanks, Chloe. I think, yes, definitely. I think there's a very, very strong role to be played by sociolinguists and social scientists of health equity in a general sense, and collaborating with doctors. And my experience, at least, in doing some of that work throughout my research for this project, is that there is actually like an appetite amongst medical practitioners for that. Like they're very, very keen to learn more and to improve the quality of care for gender diverse communities. Where exactly to target that is very tricky. So, for example, when I was doing this research, I was also connecting with some of the heads of medical faculties for medical schools in Canada. And a couple folks told me, very candidly, this is wonderful. We would love to be able to organize a module for our students on this. We just don't have the time to do it. So I think that in terms of desire for the collaboration, it's certainly there. And I do think that there are other sociolinguists as well who would be really glad to do that. The question is getting getting the medical institution to actually earmark the space for it. And so that's a little bit beyond our control. But I do agree that at the very least, there should be maybe like a parallel tactic there, right? Where there is collaboration with medical institutions that doesn't require us to have to wait until we're building training data to improve the quality of that communication. Yeah. So that's a little bit of a long-winded answer to your question, but yes. Yeah.
I think we might as well take one more question. There's so much interest. I'll give it to you since I came to you first.
Hi there. Thank you so much for the talk. It was really good. I would like I was really struck by the idea like there being like a right story.
Mm.
And I wonder if you had some more thoughts on where that right story comes from, whether it's just the diagnostic material or whether there's sort of like an interplay going there
Mm.
between various things. What your thoughts on that are?
Yeah. Thank you for that. That's a good question because actually it does come from a couple of domains, or at least the indications from my participant collaborators was that it came from actually two places. So it came from, on the one hand, certainly medical texts, where there are particular narrow representations of transgender identity and experience. And that goes all the way back to some of the earliest medicalizations of transgender identities, early versions of the third edition of the DSM, where the older folks who I talked to recalled gathering in community space basements and passing out physical copies of the diagnostic guidelines and discussing them together and kind of talking through some of that story building together. Not, of course, because they were dishonest or seeking something that they didn't have the right to have access to, but because there was an understanding that the medical authority to grant that access was very precarious, right? And so hitting the right notes was key. But also over time, a lot of the details of this right story have also emerged within transgender communities themselves. So I mentioned a little bit at the outset doing some virtual ethnography as well. So my online ethnography was on queer and trans, or particularly trans communities, although they were also queer as well in many respects, where they discussed the kind of the politics of medicalization. And there are some within trans communities who do align very strongly with medical criteria, and who do think that a diagnostic process is the right way to do it. It's a way to get it covered through health insurance and a way to achieve some societal recognition. So that's come to be known as transmedicalism for those who might not be familiar with the term. So the right story is kind of informed by both of those domains. On the one hand, there is a medical pressure, a pressure within the medical institution to align to diagnostic criteria, but there's also pressure from within the community as well to be model trans patients in a way, to be as legible as possible, so as to not paint a target on the community. So there was a lot that went into that. It's very complex, but yeah.
Awesome. Thank you, Lex. So we are going to head into a coffee break, which will be a bit more extended. So I think we'll reconvene at about 4:35. I would encourage you to, if you have more questions for Lex, feel free to interact with them. Also, Judith from Apple is here, and I believe she's happy to talk to you about any questions you might have about the hiring process at Apple, internships, full-time positions. So we'll see you in about 30 minutes. Oh yes, let's thank our speaker again.